Hello, I'm Andrea Dierup, Professor of Pathology at Duke University School of Medicine, where I'm the course director for our medical school pathology course. I'm also a co-editor of Robbins' Essential Pathology and of the upcoming edition of Robbins and Kumar Basic Pathology. This is the third talk in my series, Race in Medicine. In the first talk, we looked at race and how it is addressed in a very popular and useful pathology textbook. In the second talk, we discussed what is race. And now I'd like to talk about why are there health disparities? Because in the earlier talk we discussed the fact that biological race does not exist. So race is not a biologically useful construct. So why are there racial disparities in health and disease? So first let's ask the question, are there disparities in health and disease? And yes, there are. So here are just some examples of in the incidence of cancer and cancer death rates based on socially defined race. And you can see we're looking here at cancers of the colon and rectum, of the uterine corpus, and breast cancer. And you can see quite clearly there are very clear differences between these socially defined races. But we don't need to just talk about cancer. Why don't we talk about something which, two entities that are very common, which are largely considered to be environmental. So we have hypertension and diabetes. Now, we're using the terms here that came from this particular paper, so it refers to patients as whites and blacks. And what they are showing you here are what they call heat maps, looking at the incidence of hypertension and diabetes in these two populations in the United States. And similar to how a weather map would look, you would think that areas that are red have a higher incidence than areas that are blue, so they are hotter. And you would be forgiven if you looked at this and you thought there was a crisis in the health of whites or patients of European descent, because clearly there's a lot more red here, and it's very focused here in patients of African descent. However, I'd like to bring your attention to the scale, which can be a little bit difficult to see, but here you can see that when we're looking at hypertension in European Americans, the scale goes from 44.8 to 58.1, which doesn't even meet the lower limit, right, for when we're looking at hypertension in African Americans. And here as well we can see for diabetes, 19.6 is the upper limit, so that's the dark orange here, or the red, which doesn't even come up to the lower limit of when we look at diabetes in African Americans. And if we were to use the same scale, this is what it would look like, right? So it's much more dramatic. And clearly there are differences, right, between socially defined races. So why is this? Right? We've just talked about in a previous lecture the fact that biological race does not exist. So there are some intrinsic causes for health disparities, and I'm going to go through these in some detail. So we talk about, so I did my undergraduate degree at Princeton in evolutionary biology, so this is a topic of great interest to me. So these we're looking at here are going to be genetic issues. So we have this idea of the founder effect, or the population bottleneck. So here you can see you have a population, the different colors represent different alleles. If you have a small population that heads off either because, for example, their population was decimated, as in what happened with the American Indian genocide, or in the Holocaust for the Ashkenazim in World War II, you'll see that you have a rare allele here that may completely disappear, right, as this population expands. In another instance, you may see that that allele becomes much more common through random assortment. And this is, for example, the incidence that you would see of severe combined immunodeficiency in Navajo and Apache populations. All right, so this is a founder effect, or a population bottleneck. And it's important to recognize that we're talking here about populations, right? So this is not a socially defined race. There's also the process of endogamy and of selective advantage. So let's talk about those as well. This is a really excellent paper which came out in Nature Genetics. And I think it's really important from a conceptual point of view for you to understand this. So Endogamy is the process of marrying, or more exactly, to speak more accurately, breeding within one's particular group. And this can be based on caste or geography, family ties, language, religion, lots of other factors. Okay, and so this particular paper looked at over 260 distinct groups in Southeast Asia. Right, so you can see here they're defined here by their linguistic group. And they did some beautiful molecular genetics on that and showed that 81 of these groups showed more loss of genetic variation than you would see in the Finns or the Ashkenazi Jews. And when people are talking about groups that have reduced genetic variation due to population bottleneck, the people of Finland and the Ashkenazim are two groups that are commonly invoked. But here you could see that there were 81 groups in this small area, right? So when you're thinking about, they talk about Asian as being a race, right? So on the census documents, or when you look at what your patients are filling out as their intake forms, they have to put their self-defined race. You can't even say anything within the population of India, much less all of Asia, right? There's so much variation just in this one particular small area. So this should add further support to the belief that these broad categories of socially defined race, which we use in the United States, are really not useful from a medical point of view. And then, of course, we have selective advantage. So this is, once more, the sickle cell disease allele, so hemoglobin S. And once more, just to highlight, because in America we really do focus on sickle cell is the African American disease, and you can see that that's really not the case, right? So we see here along the Mediterranean and the Middle East and in India. Okay, so these are three things, so founder effect, endogamy, and selective advantage, that can create genetic causes of disparities, right? So you can also just get random drift of alleles, and we see these things, and there's a lot of research being done teasing out these subtle differences, and this group has 15% more than this group. And the question is, A, is that clinically relevant, right? Is that really useful? B, is it have as great an impact on an individual's health as these environmental factors? And the answer is, probably not. And that's a topic for another talk. All right, so we have these causes of disparities, these intrinsic or genetic categories, right, these causes. But then there are others, and this is not a comprehensive list, right? But these are the extrinsic causes, and these have a huge effect on health, right? Poverty, right? Access to care. A lot of the discussion we have has to do with, does this person have this particular mutation in this breast cancer? Well, if they can't get to the doctor because they don't have health insurance, or they don't have someone to take care of the kids, or they can't get to the hospital because they don't have transportation, or they can't leave their job, that is a much bigger impact on their health than whether they have a particular genetic variation. Okay. Now, when we look at these extrinsic causes of disparities, a lot of them are linked. So poverty is going to be linked to access to care. The neighborhood someone lives in, living conditions. Is there going to be increased lead in the home? We know that a number of socially defined races, typically the ones that are lower on the socioeconomic status, that are not in the dominant group in this country, tend to be in areas that have greater environmental pollution, nearer Superfund sites. We might have increased stress, lack of health insurance. And then we have these three here: individual, institutional, and systemic racism. And I'd like to talk just a little bit about those. I think these we're learning more about, but these are used more and more in the media. And I think it's worth just getting on the same page about what we mean by these. So this comes from the website dismantlingracism.org, which I think is fantastic. So this is talking about the three expressions of racism. So we have individual or personal racism, institutional, and cultural or systemic. And I think probably before the last year and a half or 2 years, when most of us, particularly those of us from positions of privilege, thought about racism, our conception was of personal racism. So I would think of men in white robes burning crosses, and that was something rare and uncommon and dangerous and scary. But it was a group. It was not all of society. But what a lot of us have learned has been that it's not just individual acts, that racism permeates our entire society and the institutions we're in. And these are the institutional practices that elevate or support or enrich or protect people who are of European ancestry. And so institutionals will be things like hospitals or universities. And an example of this, of institutional racism, is that when fetal ketonuria newborn testing, so PKU testing, was first done, the first site, they only tested in white children because they said, well, only white kids get PKU, which of course is not true. Okay. And then when we think about cultural or systemic racism, these are the beliefs and values and norms of our society, right? So our society in the United States does not believe in universal access to health care, which, as you would imagine, has a huge impact on health disparities. Also, the United States government supported redlining, in which properties that were owned by individuals of African descent were considered riskier and were not as available to receive mortgage support, which had an impact on generational wealth and really generational poverty. So these large issues in racism are something to keep in mind. All right, so let's take a look at how these extrinsic factors can have an impact on health. So here we have a quotation from Up to Date, which looks at two studies, one by Pollock, one by Price, of women who underwent hysterectomy. So when a woman has a hysterectomy, there are essentially two ways one could have it done. One is an open hysterectomy, an abdominal hysterectomy, in which a large incision is made in the abdominal wall. This tends to be very painful. It has a longer recuperation time than a minimally invasive technique, which could be laparoscopic or transvaginal. So if you looked at women who underwent hysterectomies, if a woman was eligible for a minimally invasive technique, so she did not have a massively enlarged uterus, say due to massive fibroids, that if she were Black, Hispanic, or publicly insured, she was less likely to receive a minimally invasive technique than a white woman, all right? And the factors that come into this, I would say, would be systemic racism, because it has to do with public insurance. So we discussed that our society does not support universal health care. Institutional racism, because the hospitals that primarily served Black and Hispanic patients tended to do fewer of these minimally invasive techniques. And then we have issues of poverty, education, access to care, and health insurance, as well as I'm sure some of these others come in as well. And then if we talk about high blood pressure, so this is a statement from Robbins' Basic Pathology 10th edition, which recognizes the prevalence of pathologic effects of high blood pressure in African Americans. Now think back to that heat map I showed you earlier, and I would say really that all of these come into play, right? So stress, anxiety, food, education, racism, all of these come into play. So these are the causes of disparities, and it's important to recognize this. It's so tempting to get drawn into the research mindset of what are the genetic differences, what are the molecular differences, let's look to see if this gene is more common or this allele is more common, and step back from that and think that the greatest cause of disparities are going to be here. This is where we can do the most good, okay? All right. Thank you very much. I hope you have found this useful. Please put comments below if this was helpful, additional questions you have, additional videos you'd like to see, and don't forget to subscribe. Thank you very much.